Good afternoon and good evening, and thank you so much for joining us for the weekly briefing from Africa CDC. My name is Margaret Edwin, the Director of Communications. I'll be moderating this session. The weekly briefing focuses on health emergencies across the continent, in addition to the Africa Health Security and Sovereignty agenda that Africa CDC is advancing. Today, we are joined by Professor Yap Boom, the Deputy Incident Manager from the Incident Management Support Team based out of DRC. I will now hand over the floor to Professor Yap to start the session. Over to you, Prof.
Thank you so much, Director Margaret. Good afternoon, good evening, depending on where press briefing today on behalf of our Director General, His Excellency Dr. Jean Casseya. We'll go through the feedback of the AU Summit. You remember last week, we were having side event on the side of the 39th AU Summit, and then you will see how we are pushing the AHSS, but also how we continue the response to the different outbreaks that are occurring in the continent. So Director Margaret, happy to have the slide, please. Thank you. So as you see, it was quite an intense and very hectic week that we had last week around the AU Summit. It was really an opportunity, as you will see in this briefing, to ensure that we leverage on Africa CDC convening power to push the health agenda at the center, at the highest political level. Next slide. Next slide. Yes. So just to remind ourselves what is the current vision and how it has been pushed during the AU Summit. The Africa Health Security and Sovereignty Agenda, it's the new vision that is coming out from the engagement with our leaders. And looking at the new public health order, that was the previous one, they support us on changing, on improving that vision to consider the ongoing environment with the challenge, the financial challenges, but also all the challenges that the continent is facing. Therefore, the 5 pillars that are within that agenda are the following: the reform and inclusive global health architecture, which was a critical discussion, as you will see later, the institutionalized continental PPPR agenda, the predictable domestic innovative and blended financing, the digital transformation, and of course, the local manufacturing. And those 5 pillars were critically discussed, engaged during the summit. Next slide. So as mentioned, we really took advantage of the 39th ordinary session of the Assembly of the African Union to ensure that health has a clear and important position during the debate and the discussion. So together with the African Development Bank Group, the AUDA NEPAD, we convey our leaders to discuss and ensure that health is considered as a pillar of sovereignty and economic transformation. And they reaffirm critically that investing in health security, it's not an optional expenditure, it's a must. It's an investment that has to be made by all our countries. Therefore, a new compact between finance and health has been highlighted, where the joint decision-making between the Ministry of Finance and health, we were all together in the room trying to discuss how we can improve the collaboration and ensuring that health is being considered not as a charity, but really as an investment, as we'll see again later. And this is critical for our continent to move from a state of dependency to domestic leadership. especially at the time when we have the reduction of the ODA. It's critical to have the transition from fragmented, externally driven financing toward an integrated national framework where we have on one side the domestic financing, but also where we innovate. One of those the innovation is the debt swap, how we can transform the debt that we have to invest them on our healthcare system. And also what has been highlighted by all our leaders, the Minister of Finance, Minister of Health, but also at the presidential level, is the need to strengthen our accountability. And therefore, Africa CDC, we will provide an annual continental progress report under the Lusaka Agenda Monitoring and Accountability Framework. That will be our guide to see how the different member states are moving toward what has been approved. Next slide. Now, on the side of the investment on the health workforce, community health and sustainable immunization program under the leadership of the president of Nigeria. The discussion was about the operationalizing the AU Health Workforce Compact under the Africa Health, Security and Sovereignty. As we've presented to you last week, we've managed to reach 1 million community healthcare workers. So it was critical to appreciate all the effort that has been put in place, but to re-emphasize that we need to achieve the 2 million by 2030. Knowing that those community healthcare workers will be the backbone of primary healthcare, epidemic intelligence, but also the PPR system. And we are seeing the health workforce really as a catalyzer, as an engine for economic transformation. The investment of $1 on them will provide $19 in economic return. So on one side, strengthening the productivity, but also on reducing the vulnerability to the different shocks that our continent is facing almost every day. So the idea is really to push to move from the financing to acceleration and the digital integration. And therefore, the aim is by June 2026 to launch a continental acceleration plan in Abuja, and also to secure 4.3 billion of annual investment that will support that ambition that we are having of having our 2 million community healthcare workers being paid by 2030. Next slide. Led by President Ruto of Kenya, the local manufacturing of health commodity was also one of the highlights of the side event around the AU Assembly. Why? Because it's a critical tool, essential to support the continent moving from our state of dependency to sovereignty in health product. Remember, taking the example of vaccine, currently 98% of the vaccine used in the continent are imported. So the commitment is to meet at least the 60% of Africa vaccine, medicine, and diagnostic need through local manufacturing by 2040. And it is possible. In one of our briefings, our DJ highlighted the experience in Algeria, where around 80% of the medical countermeasures are produced locally. So it is definitely possible. But to achieve that, we really need to push the demand aggregation through the Buy African. And that will leverage on the African pool procurement mechanism, which will serve as a continental tool to aggregate demand, the risk market, and create predictable supply. Simply saying, it's an opportunity for our continent to have all the countries all together pool their demand so that we have the power to negotiate on the price and to have better price for our countries. But also to sustain the industrial financing with a capital fund, which will provide patient capital to strengthen pharmaceutical infrastructure, because those industry need to have the reassurance that they will have the market. And 1.4 billion population definitely is an important market. And to achieve that, We need that political acceleration. And the President Ruto, our champion on local manufacturing, has convened an extraordinary summit on African health product manufacturing that will be convened in Nairobi on the Q2 2026 to really translate the commitment into binding implementation pathway. Next slide. All those events, the local manufacturing we've mentioned, the health workforce, the digital transformation, the PPPR, all those will contribute to the reform of the global health ecosystem, where we want to have more equity, a renewed leadership for health security, sustainable financing, digital transformation, and local manufacturing. So that event was really the opportunity to bring together, under the leadership of the President of South Africa, President of Ghana, and the Africa CDC, to convey other leaders. We had the head of state from other African countries, the Prime Minister from Spain, many countries and partners, Gavi, Global Fund, and many others were all around the same table to discuss how can we reform that global health ecosystem and ensure that our voice, the African voice, is being heard. It's an issue, definitely, of African sovereignty and the continental leadership. But also the need to sustain the domestic financing for our resilience. And that is also an opportunity to counter, on one hand, the declining external funding, but also we have a long-term resilience system. Was also discussed how to accelerate the manufacturing and the PPPR system. So there were a common agreement in the room so that we should fast track the regional vaccine and pharmaceutical manufacturing while strengthening the PPPR. So all those discussion was leading to a communique, but during the conversation, it was clear that there were other partners, other member states that also want to join their voice in that communique. So the communique will be coming later once all the different stakeholders will have bring their input so that we can have that communique in the next few days or few weeks. And the head of state of South Africa has also committed to have a virtual gathering so that all those who were not be able to join will also have the opportunity to contribute. Next slide. It was also following the same agenda, an opportunity to have some engagement. We were talking about the local manufacturing, and we have the visit of His Excellency Dr. Delese Mimi Dako, which is the Director General of the African Manufacturing Agency. It is critical to re-emphasize the strategic institutional alliance between the two organizations, because that is a cornerstone to Africa's self-reliance. Because we need to have that regulatory harmonization for resilience and access. There is no way we can have the local manufacturing if we don't have the strong institutions that are committed to that acceleration and the regulatory alignment. It is important at some point to have only one door where we can have those approval rather than moving in 55 member states to have an approval for a vaccine, a diagnostic of any medical countermeasure. So this conversation was really to push and drive the Africa health security and sovereignty local manufacturing pillar. So that will really strengthen our capacity to produce quality assurance vaccine, medicine, diagnostic, and therefore advance the local manufacturing pillar. Because we always remember the challenge we faced during the COVID-19, where we were left over on receiving critical medical countermeasure, including the vaccine. So by pushing that agenda all together, Africa CDC and AMA, that's how we will be able to achieve the expectation of our leaders. Next slide. It was also the opportunity to sign some memorandum of understanding, the first one with FHI 316, with the aim of strengthening the collaboration in advancing health security, workforce development, and resilient public health system across the continent, because FHI 360 is present across many countries and has been quite critical, including in the response to mpox in different countries like DRC, Uganda, and so on. But also bringing the agenda of women's and adolescent health across the continent. And the partnership with UNFPA will really strengthen and ensure that women and girls are at the center of stronger and more resilient health system. Next slide. Now, going back to our public health event, we still have cholera, which is on the top of the disease that is affecting the continent. Looking at the number of cases, 3,254 confirmed cases with 277 deaths, followed by measles, which is affecting 8 member states, mpox 21, diphtheria 6, and dengue 3. But what you can see down is the trend of the moderate and high-risk event. At the same time, in 2025, we were having 99 moderate and high-risk events as compared to 69 that we are having now. So we closely monitor those events. On one side, we have improved the capacity in countries to detect early and to respond to those events. So it's important to see those numbers decrease because the capacity in countries are also increasing, but also the relationship with the primary health care, because the strong involvement of community health workers in the community, the sensitization of the community, are critical elements to prevent the occurrence of those different events. Next slide. On the side of mpox in the continent, happily, we keep on seeing the decrease on the number of suspected cases, confirmed cases, but also the number of deaths. As compared to last week, this week we have not reported any death among the suspected cases nor the confirmed case, which is a very good outcome for last week. As per now, we have Madagascar, DRC, Guinea, Liberia, Kenya, Uganda, Ghana, Burundi, and Zambia that account for 90% of the confirmed case. And when you look at the curve, we happily see that decrease of almost 90% on the number of confirmed cases that we've been seeing so far. Next slide. Now, looking at the different country where we see some case and that we are monitoring very closely, we have Comoros, where you can see that they've reached the 16 number of confirmed cases with 34 suspected cases since almost a month, which means that the country is really strengthening the active surveillance and limiting the spread of the disease in their countries. As compared to last week, there are 3 cases that has been reported, 7 cases have recovered. And what is important to highlight is the test positivity rate, which is around 17%, highlighting that the surveillance is well implemented. However, because of the dynamic of the emergency with the 3 islands, it is critical to enhance the surveillance in those 3 islands. And that will be supported with the deployment of IMSC search team, but also to support the laboratory decentralization to ensure that the testing is being done in the different islands and reduce, therefore, the time from the sample collection to the result of the test, because when the time is long between the two, then you can have the spread of the disease. And this will be supported by the recent handover of molecular and sequencing equipment that has been delivered to Comoros by the Africa CDC a week ago, as well as the equipment for the EOC that was supported. In the next few weeks, they will also, next few days or weeks actually, they will also receive some training to ensure that they are capacitated on the coordination and the response to the outbreak. So this outbreak is actually a very good opportunity for the country to really strengthen the capacity to respond, but also to prepare the response to any other disease. Next slide. In Madagascar, we happily see a decrease in the number of cases. We were having 61 cases last week. This week we have 28 to a total of 270 confirmed cases, and 0 death has been confirmed with a CFR of 0%. The test positivity rate of 35%, also a good indicator of the active surveillance that is currently ongoing, because we have 20 out of 114 districts that has been affected. So it's critical to have that active surveillance that will also be strengthened in the coming weeks to ensure that the control of the outbreak happen in those 20 districts and not moving to any new district. But also the support will be on strengthening the contact tracing, because you can see here that we have 4 contacts for 1 case. Now, you remember that the threshold that we expect is 20 contacts for 1 confirmed case. So it will be an opportunity with the deployment of community healthcare workers to support the country on achieving that. But also the support will come on the lab after the training that had been received a few weeks ago. And of course, to support the country to prepare the vaccination exercise. The country has been allocated 30,000 doses of vaccine, while the request was much higher than that. So it's critical to have a support and ensuring that the the right population, the high-risk population in terms of vulnerability, people living with HIV, but also those who are most likely to transmit are targeted. This is a support that they will be receiving through the IMST. Next slide. In Liberia, we see some stability in the number of cases. Still, we have not reported any death this week. So far, we have 8 deaths that have been confirmed with a case fatality ratio of 0.5%, 8 deaths out of the 1,622. So, importantly, the hotspot remain the same. Montserrado and Nimba that account for almost 76% of the case. So the vaccination has started a while ago, where they were able to vaccinate 18,000 people and during the first phase. The second round of vaccination just ended today, and they've managed to vaccinate a total of 36,000 people using a very targeted approach. So we expect that in the next days, next weeks actually, we'll see the impact of that vaccination, knowing that currently they're also planning the 3rd round of vaccination. So ideally, we expect to see what we've also seen in Sierra Leone, where we have that integrated response with the operation Find Them All, together with the vaccination. That gives the opportunity of the countries to vaccinate the most at-risk population, but also, as mentioned in other countries, to vaccinate those who are the most at risk of spreading the disease. Next slide. Still talking of vaccination, we can see that we've reached the 5 million doses that has been delivered in 16 countries. But what is important to highlight today is really the effort that has been implemented in DRC. You remember that DRC is the one country that has received a bilateral donation by the government of Japan of the LC16M8 vaccine. So far, 1 million doses has been administered, and they have been using that geographical vaccination in 18 health zones across health districts in DRC. Next slide. So what you see that here is that in the country, 1 million doses of LC16 has been administered, and almost over 700,000 doses of MVA-BN doses administered. So the added value of having the 2 vaccines, 1, the reactive vaccination that has been used in many countries is being implemented, but 2, we are moving toward a transition where they are also having that preventive vaccination in districts, in provinces that are endemic for Mpox. So that is a very good example that we are going to follow and see how we can use the same example to increase the herd immunity. The herd immunity is when we have more than 60% of the population that is protected. This is a key component of the transition of mpox from the emergency to the routine. Next slide. Moving from mpox to cholera in the continent. So far we've been reported 14,116 total cases in the continent with 277 deaths with a case fatality ratio of 1.96%. We have 11 country members that have reported. So there might be some that also have some case, but some challenge in the reporting. So far, DRC, Mozambique, Nigeria, and Burundi are contributing to 95% of the case reported, while DRC alone report 69% of all cases and 80% of all reported deaths in 2026. Next slide. When we now look at all the countries that are reporting cholera currently, we have those, Zambia, Malawi, and Mozambique, where we see an increased transmission. The case has been increasing in the most recent 3 weeks, and you can easily see that those countries are part of the same Southern African region, which is a critical stimulant to move with that regional response that is being prepared with the IMST, with the WHO, AHSS, UNICEF, to ensure that we go and support together also with the World Bank and ensure that we have a regional coordinated response, because in those countries, every year, because of the flooding, because of the seasonality, those outbreaks are occurring. So now we are thinking how we can, in one hand, stop the outbreak, but also have an impact so that when the flooding comes next year, the access to water has changed, and therefore we don't see the same trend that we are seeing currently. In Somalia, Angola, Namibia, and Burundi, we see a mild decline, where so far South Sudan and Sudan have not reported any case in this year, 2026. Next slide. In Zambia, we have a slight increase in the number of cases from 68 last week to 89 this week. So far we have been reported 16 deaths out of 86 cases with a case fatality rate of 1.2%. The challenge that is being faced remain the same as we will see in many of those countries: the access and logistical challenge hindering the response in affected flooded province, but also the poor wash infrastructure and the multi-outbreak response, the flooding as well. So you have a mix on the climate change with the recurrent flooding, but also the fact that the country is responding to many outbreaks and therefore challenging the availability of the resources, both financial, but also human resource. Next slide. In Burundi as well, we see stability in the ongoing outbreak of cholera. The case fatality ratio is 0.4% with 16 deaths out of the 3,900 cases. And the infrastructure, though they are fragile, what is important to highlight for Burundi is really the emphasis of the multi-sectorial approach with an important involvement of the private sector to ensure that, once again, they respond to this specific outbreak, but in the meantime, they ensure that they have increased the access to water. The challenge that they face is also one of the key reasons of the outbreak is the migration due to the insecurity that is happening in the eastern part of DRC. Next slide. Talking about DRC, remember that the country account for over 70% of the case and 80% of the death. So the key driver in the country remain the same: the conflict and displacement on the side of the east, but also the seasonal flooding and heavy rain that have also contaminated the water source. And we see it in the South Kivu, North Kivu, Olomami, Okatanga, and Kinshasa, the capital, and that make 80% of the case reported in the week 5. So far, 21 out of the 26 provinces has been affected, with a case fatality ratio of 2.78%, which is pretty high, as we are really pushing toward going down to 1% of case fatality ratio. So this reminds us the urgent need to control in Kinshasa, but also in the different provinces, despite the challenges that we know on the access because of the humanitarian crisis. Next slide. In Uganda has been reported a new outbreak, this is not the first time, of in that region of Crimean Congo hemorrhagic fever. So far, only one case has been confirmed, a nurse likely exposed to livestock on the farm in Kagalama village, which is on the town of Butemba town. So an animal disease outbreak, this is the Crimean Congo hemorrhagic fever, which has been happening in the country since December 2025. So the country has already activated the regional EOC. The patient has been isolated and well taken care of, while the investigation and the contact tracing are also happening. Next slide. So as mentioned, as you've been able to follow, we've been having a very important week on the side of the AUC summit with the different side events that are really brought health at the highest political level. One on advancing continental self-reliance, health financing, compact for strategic investment, scaling the health workforce with the 2 million community healthcare workers by 2030, to support the PHC and the PPPR, but also the critical local manufacturing, a key pillar for our sovereignty, with the commitment of 60% of Africa medical countermeasure needs through local manufacturing by 2040. And of course, the event, extraordinary mid-summit that will happen in the Q2 in Kenya. All that is pushing, is moving toward the reform of global health architecture, where the voice of the continent will be more and more heard in all the different fora. As mpox is concerned, we keep on seeing the sustainable decline, which is a strong catalyzer to move the mpox into the routine. At the early March, we'll have that review that will happen in Kinshasa on the side of the after action review for mpox and the intra-action review for cholera. And as seen, the example of DSA vaccination remain critical, not only for the response, but more importantly, for the prevention. Because we remember the vaccine aim to prevent. That's the first aim, which we believe will be done for mpox and lead us to the agenda of local manufacturing. Because if we want to achieve the herd immunity, it means that in a country that has been endemic for mpox, we need to provide enough vaccine to that population to protect them, and therefore to have them produced in the continent. As cholera is concerned, DSA is really the epicenter of the outbreak, with almost 70% of the case and 80% of the death. The rising surge in Southern Africa is a critical catalyzer for our regional coordinated approach, which is ongoing. And that's also a reminder that the climate and humanitarian pressure are some of the key drivers of the cholera outbreak that we see in the continent. So with that, I'll be happy with all my colleagues that are currently connected to take any question that will be coming from the audience. Over to you, Director Margaret.
Thank you very much, Prof. Let's take the first two questions. We have one from Charles of The Guardian. The question is, why is the world finding it difficult to come up with drugs that will permanently resolve Lassa fever, just as was done for HIV? That is the first question. The second question is from Yarsir Jamal of Nigeria Health Watch. The question is, when a global health study approved by international institutions raises ethical concerns within an African country, what role should Africa CDC play in determining whether such research proceeds, and how does the agency balance scientific inquiry with other considerations? I'll hand over the floor back to you. I think the second question should go to Dr. Fala. Over to you, Prof.
Yes, actually, I will let Professor Fala answer the two questions. I think he's connected, and because he has been working quite significantly on the Lassa fever of late. Dr. Fala?
Thank you very much. The overall issue, so to just make correction, there is no permanent treatment for HIV/AIDS. We don't know that we have treatment to suppress below detection level and it reduces spread. But we do know that all antivirus, the thing of viruses is that we have high mutation rate. It's not easy. And then if you are in the case of Lassa fever specifically, it's a disease of poverty, it's a disease restricted in a smaller region. Motivation for treatment because of the market forces. In fact, if you come back to what Professor Yab was saying about our sovereignty, when the big pharma companies are going to depend on market size. Having said that, we've been using ribavirin for a long time to treat Lassa, but we know it's not the most effective treatment. It has some side effects. But the good news is that multi-countries and institutions have come together to develop a vaccine for Lassa fever, including CEPI that has funded it, ERV that had the candidate vaccines. We're happy to note that through those combinations, the phase 1 trial has been successfully conducted in Liberia. Now they are beginning phase 2A trial in Nigeria. The hope is that this is going to be a new and a novel approach where you're going to have ministries of health, countries coming together. I was in one of those meetings to try to fund it. So it's going to look at regional funding by member state towards getting a successful vaccine. So at least the initial findings show promises. And you know, in all of our public health response in the world, whenever we have a successful vaccine, it is a major breakthrough. So indeed, people have been paying attention to Lassa fever. We are on the way. There's a 2A vaccine starting. It will go all the way to a phase 3 trial. So we closely monitor this, and there is a multi-agency committee organized by WAHU, Africa CDC, WHO, and the ministers of health moving this forward, of course, support from CEPI, major our donor partners, ERV. So there is progress towards finding solution to Lassa fever. As we know, vaccine is one thing that helps us to solve a problem. So basically, that's the way we work. When a disease comes, we look at the prevalence of the disease. Then there are multiple cases right now with the kind of work that is done, finding the disease in a region, but there are multiple antiviral vaccines and treatment in the pipeline. But you know, getting a final bullet takes time and years and a gradual process towards developing vaccines. But we are now developing different models, like the Lassa fever model that is getting countries and partners and funders to support it. Thank you very much, and back to you.
Yes, Papa, there was also the second question on the role of Africa CDC when there is a study that raised ethical concern. And I know that you are putting all together this platform of scientists that can really support in the term of ethic and monitoring board.
Yes, indeed. We've been writing this concept, thanks to Professor Yap and others, to have this continental body of prominent African scientists and ethicists that will be around from multiple countries. And whenever countries have an issue to look at, they want an external opinion to guide and advise them on ethics or the scientific rigor for any study, they can consult. We're working internally, we've developed the concept, we've worked around it. In the couple of coming weeks or so, we'll launch it. It will be an independent body of scientists that can always be available to Africans to review studies that are coming up. Thank you, sir.
Yes, thank you, Papa. And in the meantime, Africa CDC is also strengthening, building the capacity in countries for the ethical committee to ensure that they have the capacity to assess those protocols. And once they feel that it's more complex than the resources that they have available to them, then they come to Africa CDC to find experts, as just mentioned. Over to you, Director Margaret.
Thank you very much. Professor Fala is the Director of Science and Innovation. I will now cross over to the floor. We have Helen from START. Helen, you have the floor.
Hi, thank you very much for doing this very interesting presentation, and thank you for taking my question. It kind of follows up on the second question there, which I think was about, or at least touches on the issue of the proposed hepatitis B birth dose trial in Guinea-Bissau. Last week, Professor Beaumieux said that you thought there might be some news this week, that you thought that there would be conversations at the African Union meeting with the officials from Guinea-Bissau. Did you learn anything more about the status of this study? And yeah, that's it. Thank you.
Thank you. Let's take the next one before the response comes in. We have Paul from the Lancet. Paul, you have the floor. Paul, if you can hear us.
Can you hear me?
Yes, we can hear you. Go ahead.
Yes, thank you very much. So my first question is in connection with the AU Summit. You've given us a lot of updates from it. I would like to know whether there were any other updates or developments around non-communicable diseases, specifically cancer, other than the rollout of vaccines to support African countries in preventing cervical cancer. So what were the NCDs and cancer development at the summit? I also want to ask a question. You mentioned local manufacturing, capacity building. We've been having this conversation on improving local manufacturing in Africa for a while now, and I think the DG once shared the timeline. So where are we currently at with the timeline? And a lot of conversations I've been having with stakeholders in this sector said the person that pays for the vaccine has a bigger say regarding where the vaccines will be produced. So what are the biggest funders of health vaccine procurement saying regarding supporting or aggressively funding local vaccine manufacturing on the continent? And if I can squeeze in a little thing, which I think is best described, shedding more light. You mentioned the Crimean Congo hemorrhagic fever. This is not a routinely screened for disease in Africa. So if we can get insights into how the team in Uganda were able to unpack that particular disease to establish that specific diagnosis. Thank you very much.
Thank you. Thank you. Yes, I think we have some very good question as usual. I was expecting that question from Ellen. For the Congo in Crimean hemorrhagic fever in Uganda, I think Dr. Messi will be happy to respond, and then Dr. Landry will respond the one on the NCD, as this has also been part of the discussion, though we are not able to present everything. So, Ellen, to your question, we still don't have a clear feedback on where the process is going on. But what we can say is the reassurance that the country itself, Guinea-Bissau, will communicate once all the process is done on which direction they will be taking. So I will hand over to Dr. Landry on the question on the NCD around the AU Summit.
Yeah, thank you so much for the question on NCD. It's important to highlight that when it comes to non-communicable diseases, Africa CDC, as part of the primary health care center priorities, has established a strategy, a continental strategy for the prevention and control of non-communicable diseases, injuries, and mental health. As you know, they represent conditions causing a substantial human and economic loss to our continent. Almost 75% of Africa's disease burden, causing over 1/3 of all deaths. So the African Union, during the last summit, had the opportunity to table on what is now called the multi-sectoral engagement and coordination and action plan, which is part of the common position that Africa is putting together to address non-communicable diseases, injuries, and mental health. So this is an important piece which comes to support the already existing African Union, Africa CDC multi-sectoral task force on NCD, injuries, and mental health. And why is it important for Africa? It's important because what we have seen in the space of NCD is the multi-sectoral need to address not only the prevention component of NCD, but also the care and support. And within the primary health care, there are ongoing initiatives, not only to build the capacity on the continent on non-communicable disease prevention, care and treatment, but more importantly, to build the capacity for the integration of NCD within the routine package of primary health care. Thank you.
Thank you, Landry. So Dr. Mercy will go on the question of Congo Crimean hemorrhagic fever, and then I will give some few updates on the local manufacturing, which will be completed by Dr. Landry as well. Over to you, Mercy.
Thank you so much, Prof, and thank you for the question. I think it's important for us to note that this particular event is not the first time that's been reported in Uganda. So Uganda has been reporting sporadic cases of Crimean Congo hemorrhagic fever, over the past years. So they reported last year and they reported this year, but it's more or less sporadic. And we know that the mode of transmission is through tick bites. So more or less that also helps in the investigation and also points to the direction of the testing. So basically, because Uganda has been prone to some of these hemorrhagic fevers, they have trained their healthcare workers on community case definitions that really facilitate the rapid detection of some of those public health threats. And that really streams back to our agenda on the continent to train over 2 million community health workers. So Uganda has taken a step further to do that and train them on using those case definitions to pick those acute febrile illnesses. And once that is picked, mind you, there are so many of these diseases that present similarly. So what happens is that they go ahead to do differential diagnosis, and that also helps them to be able to detect what specific hemorrhagic fever they are dealing with. The source of exposure as well also gives a pointer to some of those things. So it's a blend of several capacities that have been built over time, and the history of detection within the different communities that also helps them with some level of awareness on these different pathogens. So basically, that's what is happening in country. So the index of suspicion amongst healthcare workers is quite high because that's something that they have been experiencing in the past.
Thank you, Dr. Mercy. And also this also build on the strong laboratory capacity that Uganda has with Uganda Virus Research Institute, with the CPHL, where they have all the tool, the equipment, but also the expertise to quickly detect those viruses. So going to the question of local manufacturing, I mentioned that definitely we appreciate that 99% of our vaccine is a strategic vulnerability. So what has been done so far is, one, to really set a bold target. You mentioned, those has been mentioned, 60% of our health product needs locally by 2040. This is the starting point. So what has been done so far is really the operationalization of the African pool procurement mechanism. This is our Buy African, where we really want to aggregate the demand and to make sure that it is profitable for the manufacturer. So this engagement is happening. But on the other side also, we need the capital support. So because manufacturing is capital intensive. So what Africa CDC is doing with the APPM Capital Fund is to provide the patient capital with longer repayment horizon than traditional banks, so that the manufacturer, the local manufacturer that we will invest, know that they will have the return on investment. So the last thing is the high level support. And I mentioned that in the Q2, in Nairobi, there will be that extraordinary summit on African health product manufacturing. Now, going back to your question of what is the position of the buyers. So Gavi is the strong supporters of the local manufacturing agenda. So maybe I will let Dr. Landry to emphasize that and any other point that you need to be complemented. Dr. Landry?
Thank you, Prof. Yap. I think the point you raised about the need to understand that local manufacturing is an entire and complex ecosystem. It is important to clarify that the continent has taken that bold step when our head of state gave us a target of having 60% of the vaccine utilized on the continent by 2040 should be vaccine procured on the continent or manufactured on the continent. And that bold state gave birth at that time not only to the Partnership for African Vaccine Manufacturing, which was elevated now to include not only vaccines, but also medicines and diagnostics, was definitely another momentum because as the DG of Africa CDC, Dr. Jean Kaseya, always emphasized, local manufacturing would be the second independence, or is the second independence for Africa, because it's also an agenda of health security and it's a manifestation of our sovereignty. So coming back to the vaccine, I think you mentioned the AVMA, the African Vaccine Manufacturing Accelerator, which is an initiative supported by Africa CDC and led by Gavi at global level to really support local manufacturers on the continent. And AFMA has established a clear strategy. I think what is important to highlight here is that on the continent today, we have a market. And the recent study indicated that when it comes to the number of manufacturers on the market, for the vaccine, I think we are numbering close to 53 or 57. But if you compare to our population of 1.5 billion people, comparing to China, where you have a comparable population of 1.5 billion people, where the China manufacturing company for vaccines estimated at 10,000 manufacturers. If you go to India, comparable population of 1.5 billion people, it is close to 5,000 manufacturers. So the continent, when it comes to the market, we have the market, but it's not only about the market. The vision is that we want to produce, as a continent, vaccines, therapeutics, and diagnostics that are good for Africans and good for the world. Thank you.
Thank you, Landry. Over to you, Margaret.
Yeah, thank you so much. Let's cross over to the floor. We have Rachel Abuja from Nigeria News Agency. Rachel, you have the floor.
Good afternoon, everyone, and thank you for having me. Prof, my question is for you. We all know the programs for farm are truly expensive now, and it's telling on Africa out of pocket is high. Are we looking at having generic drugs, or what's our take on it? Again, for local vaccine manufacturing, we still have manufacturing complaining that government of the day do not support them, and they don't see all of this coming to bear. What's your advice? And how are you collaborating with government? Because we've been on this for over 5 years now. So let's hear from you. Thank you, and over.
Yes, thank you so much, Margaret, for reminding us that the issue of out-of-the-pocket expenditure is a critical challenge for our population. This means that instead of having an environment where our population can have access to drugs, to services, they have to pay it by themselves. So what has been highlighted and seen is there are many ways on reducing that out of the pocket. The first one that has been highlighted during the conversation that was happening with the Minister of Health and Minister of Finance is if we manage to reduce the inefficiency in our healthcare system, there is a substantial amount of money that can be collected. Taking the example of DSC, we've seen from studies that $800 million are they're diverted every year because of the ghost workers, which means by digitalizing that environment, the country can recover that money and therefore make it more accessible, the health services, which will make it easier for the community and therefore reduce the out of pocket. That is one. Now, specifically on the side of the generic drugs. So this is what Dr. Landry was talking about with the AFMA, where we are moving toward a stronger support of the local manufacturer so that in the next 2 to 3 years, we can have more product locally produced that will be in the market. Because once we have them we have the sovereignty, but we also have a lower price, which will make it more accessible for our communities. So for your second question, Rachel, so I mentioned that Africa CDC, we leverage our convening power. We had that side event that was led by the President Ruto. We'll have the extraordinary event in the quarterly 2 in Nairobi. This is where we emphasize the critical need to address the issue of local manufacturing, meaning that on one side, we want to produce, that's clear, but also with the pooling mechanism, we want all our countries to gather so that we can collectively procure our drugs, vaccine, and medical countermeasure with a preference for the African product. That's what we call the buy in Africa. So that it will be an important incentive for our local manufacturer, because definitely it will be a challenge for our local manufacturer to produce some drugs, which we know will be a bit more higher in terms of price at the beginning, because they don't have the same volume as compared to the products that are coming from out. But it will be a political decision for our member state to prioritize those products. So this is where we are moving, and this is why it's critical for our organization to ensure that question is really taken at the highest level of the continent. Over to you, Margaret.
Thank you, Prof. Let's take the last question here. We have a question from Esther Nakazi, a science journalist from Uganda. The question is, can you give us an update on Comoros and Seychelles? The mpox situation update and what interventions have been done so far, and can we get someone? Yeah, I think that's basically the question. The other one is from James Chikawa, a journalist from the Southern Africa Coordinator, Africa Parliamentary Network. The question is, how can African countries balance the preservation of traditional medicinal knowledge with the need to adopt modern evidence-based healthcare practices to improve overall health outcomes, and what investments can we make to make traditional medicines a viable part of the healthcare systems? Back to you, Prof.
Okay, thank you so much. The second question will be answered by Dr. Musoka. There's an important work that has been done on traditional medicine, which also linked to the issue we were just talking about, the local manufacturing. So as mentioned for Comoros, as per now, they have 16 confirmed cases out of the 34 suspected cases that they've been having. So what we can say in Comoros is really they've been having a very good preparedness in ensuring that they have a strong surveillance in the different islands, because before they have any case, they were already preparing in the surveillance on one side, but also in the laboratory in the second part. So to support those efforts, Africa CDC has ensured that the laboratory equipment for testing, but also for sequencing, has been increased in the country so that they can move toward the decentralization of the response, but also on the EOC, the Emergency Operations Center, where all the coordination for those outbreaks is happening. So I think that for it. And then Dr. Musoka, maybe you can come out on the issue of traditional medicine.
Thank you so much. We are making very substantial progress in harnessing the knowledge from traditional medicine, but now we are calling it natural therapeutics. We already have a big network of over 100 African scientists. These are people with PhDs and MDs that are looking at different molecules. Even as we speak now, we have 2 molecules that are going through advanced scientific processes for mpox, but we are advancing this very rapidly across the continent because we know this is knowledge we've had. There have been issues with like toxicity putting it through the chemical composition. So we're really moving it and making it very scientific. We have, in the coming year, we have as a target to produce 3 unique molecules for mpox and other viral diseases. So this is really progressing well. We'll be publishing a very highly scientific paper, impact scientific paper in the coming days, with all of these scientists laying the groundwork for accelerating discovery and in vitro and advanced scientific development for traditional medicine, looking at both outbreak-related diseases and chronic diseases like sickle cell, diabetics, and etc. This has really been advanced by Africa CDC and scientists and university professors across the continent. Thank you.
Yes, thank you so much, Papa. It's a really a critical pillar of the local manufacturing. And just to come back to the question, I answer for Comoros. So on the side of Seychelles, they are really also, as Comoros before, on the preparedness. So far, no case has been officially declared, but they are really strengthening their preparation in case they have any positive case. But so far, there is no case that has been officially reported. Over to you, Director Margaret.
Thank you, Prof. Thank you, Dr. Fala. And with that, we have come to the end of the briefing this week. Okay, one word for Dr. Landry. Back to you.
Yeah, on the just to get the figure right, on the manufacturers on the continent, I stated that on the continent, we have 574 manufacturers based on a study that was completed by Africa CDC and partners last year, including 25 for vaccines. And you compare that with China, where the number of manufacturers is estimated at 5,000, and India, where the number goes to 10,000. Thank you so much.
Thank you, Dr. Landry. So back to you, Prof, for your closing remarks.
Thank you. Thank you so much, colleagues who were joining me on the call, but thank you so much to the journalists for being there, taking the right information and serve as a catalyzer of that information in the different countries. And also thank you for all the colleagues who are battling in the member state, responding to all those different outbreaks. As you've seen, we are going to a very critical era with this new vision of Africa health, security, and sovereignty. We really want to strengthen the health financing with quite a number of innovation, the local manufacturing, including the traditional medicine that has been highlighted, also the preparation and response to outbreaks. So all those are pushing the voice of the continent and reshaping, reforming the global health architecture. And as you've seen, we are not doing that alone. We have our partners, we have the other member states, because it's a question of sovereignty. So we thank you for your time, and then we hope to see you next week, the same day, at the same time. Thank you.
Recording stop.